And this session is regarding the smart use of, the application of combination therapies and the management of type 2 diabetes. So, it's always challenging to manage diabetes. And one such challenge is, to control the number of medication the patient actually needs. Because you have to address the glycemic control on one hand, and you have to, address the complication and, of course, the comorbids and so on and so forth. So this session actually, loaded with information which will, answer these kind of questions. So just in the interest of time, I'm going to, announce and call upon the stage the respected panelists for this session. And these are going to be Professor Najmul Islam Saab. Please, sir, join us on stage. He's a renowned physician and endocrinologist. He's currently working at Aga Khan University Hospital, Karachi, and he has, number of, contributions to the field of diabetes and endocrinology. Our second chair is Professor Khadija Irfan. Madam, please, you too, join us on stage. She is working at Services Institute of Medical Sciences, Lahore, and of course, she has got, many distinctions under her name. So these are our panelists. Now I'm going to very briefly introduce the speaker for this very session, and this is Dr. Saeed Ahmed Mahar. He's a professor of endocrinology at the National Institute of Cardiovascular Diseases, Karachi. He was the past president of Pakistan Endocrine Society and so of the past president of the ACE Pakistani chapter as well. Again, he has got a number of contributions to endocrinology across the country. So please join us on stage. Please welcome him.
Thank you very much for the kind introduction, Dr. Yaqub. It's a pleasure to be here, as always, in the Symposium of Pakistan Endocrine Society. I will try to keep in time. So the concept of combination therapy. So anyone who can, I think so I'm coming down instead of making it a lecture, make it interactive. Okay, so what is the main advantage of a combination therapy? Compliance, anything else? Very good. So superior control with enhanced patient compliance. So we need both things. We need compliance and we need the control of the diabetes. This is actually the logic behind all the combinations what we are seeing it. So we are a nation of 245 million people. We are the 5th largest population in the world, and we have what I say, we have got 33 million people with diabetes, which again is the 3rd largest diabetes population and has got the highest prevalence of diabetes in the world. This is something which is really alarming for this part of the world. And 40% of population lives below the poverty line. You can imagine that how prevalent is the diabetes, how populous we are, and how we are looking at the things. So this is something which is really alarming and actually a food for thought for all healthcare professionals. Now, ADA guidelines, just focusing on the key elements. Now, in ADA guidelines, if you look at it, the goals are the prevent complications and optimize the quality of life. Few years back, when maybe 10 years back, when we have started, so there was an approach that we usually focus mainly on few things, but now things have really been changed. So what we look, or what are the guidelines say, that you have the prevent the complications. Now, the main complications, I hope, they will be, number 1, the atherosclerotic cardiovascular disease. Fortunately, I'm working for the last 10 years in one of the largest cardiovascular center of Pakistan, National Institute of Cardiovascular Disease, Karachi, and where we do see young chaps, ages 25, 30 years of age with MI. And at least 10-15% of them, they come with the newly diagnosed diabetes and then don't know about that they have got the diabetes. So this is one thing. The second thing is actually the heart failure. This is something which is again common when someone has got diabetes or long-standing diabetes. This is something which is common. The third thing is actually the chronic kidney disease. So we all know that in diabetes, the major complications are actually the cardiovascular complications, the renal complications. So these are actually the two main things. As I said earlier, about 1/3 of the patients who have got the diabetes has got the cardiovascular disease. What is the main mortality in cardiovascular patients? किस वजह से आपका कार्डियोवैस्कुलर का अपना डायबिटीज का मरीज जो है ना वो मोर्टेलिटी किस में होती है, क्यों मरता है? Anyone? Cardiovascular, very good. Anything else? Then again, main complication renal failure. But the main mortality is either the cardiovascular disease or actually the cerebrovascular accident, we call it the stroke. These are actually the main complications. Though 40% of patients, we have said earlier, has got the chronic kidney disease, and which is again something which we do see. So what we call it as chronic kidney disease, heart failure, atherosclerotic cardiovascular disease, and type 2 diabetes is actually cardiovascular kidney metabolic syndrome. Now, if we look at the American Diabetic Association Modification Diabetes Education, now the most important thing, agents with cardiovascular and kidney benefit. Now, glycemic management, blood pressure management, lipid management, these we were doing for a very long time, and we were discussing all these. But if you look at the newer guidelines, they now are looking at that agents who have got the protection for the cardiovascular and for the renal, they are the preferred agents of choice in these patients. So, initial management, we all know lifestyle management, and then we always say metformin is the first cheap, long-standing data, which is something which in a country like ours is least expensive. Then the SGLT2, then either a GLP-1 or a DPP-4. Now, these are actually the main groups in which you prefer to give to your patients, that they prevent the complications and they do not gain the weight, which is again something nowadays a main concern. If we move further, then for the orals, if we say, because GLP-1 in Pakistan is mainly available in the injectable form, although in the world it's available in the oral form also, but in Pakistan we don't have, so we have got the injectable form. And we all know that injection is a something which is patients don't like it. आप किसी को भी कहें, जब भी आपके पास मरीज आए तो GLP-1 के लिए भी कहेंगे कि once a week है, they'll be, honestly speaking, they are reluctant to do it. But something which you offer them, that this is a pill that will give you a prevention of the cardiovascular disease, that also reduces your weight, they will say yes. ख़वातीन तो बहुत कहती हैं डॉक्टर साहब यही गोली दे दें, ठीक है हम इसको लेने को तैयार हैं. So this is something which we call now actually for today's talk is actually the triple combination. Now, some of the studies on the triple combination, AMPA, the first drug, which is the main actually the drug in this triple combination. Now, this is some EMPA-REG outcome trial, one of the most famous trial you come across in many meetings. Its main actually look at the cardiovascular outcomes. Now, what it shows that someone who is on EMPA that has got 14% decrease in major adverse cardiovascular events, 38% decrease in cardiovascular death, 35% decrease in heart failure, and 32% decrease in all-cause mortality. So, the reduction in cardiovascular outcome mortality was generally consistent across subgroups and analysis population. So, this is across the whole groups. So, EMPA can give you all these cardiovascular benefits when somebody who is on the empagliflozin. So, treating 1,000 patients with type 2 diabetes at high risk of cardiovascular with empagliflozin for 3 years, now it saving the 25 lives, preventing the 25 deaths, and preventing hospitalization for heart failure. Then again, something we have got definitely the drugs has got the side effects also, but definitely we look into the genital infections and the genital leading to the discontinuation was one of the reasons. Now, we did a study in Pakistan because we have got different the methods of ablution and all these things. So the Western people have got the dry and we have got the wet. We use water for all these things. So we did a study in Pakistan, and we found that the percentage of infection is moderately low in comparison to the Western world with the empagliflozin in these patients. Heart failure, again something, the emperor reduced, emperor preserved, and empa kidney. All these actually have shown that empagliflozin in type 2 diabetes decreases the HbA1c, cardiovascular, decreases the adverse cardiovascular events, hospitalization and heart failure, renal disease, decreases the need for dialysis, decreases the decline of estimated GFR. So if you put somebody on an EMPA, that actually improves the cardiovascular outcomes in these patients. Now, FDA actually approved the drug, the EMPA, August 2014. Then for the cardiovascular and heart failure, 2016. And then again, heart failure with ejection fraction without diabetes, 2021. Then again, preserved ejection fraction, 2023. And the CKD, 2023. So the good benefits or good outcomes of the drugs, they are being added. Now, the cardiologists say this is our drug, nephrologists say this is our drug, diabetologists say this is our drug. So this is actually something which is combined for all the subspecialties, because we all have to treat the patients. Another compound is the linagliptin. This is again a DPP-4 inhibitor, and there are some certain peculiarities. DPP-4 actually, this is an enzyme which actually prevents the degradation of the GLP-1, and this is the oral, again an oral medication. These are the benefits of linagliptin, that it's once a day, number one. There's no increase in heart failure. Cardiovascular safe. Its main thing that is it has got the renal safety. It's weight neutral, and again the low risk of hypoglycemia. So if you look at the linagliptin, now has got the renal safety, weight neutral, no increase in heart failure, and the once daily dosing. So again, we have got quite good experience like metformin with the linagliptin also. How many of you are using the lina and the EMPA combination? Good. So how you found the drug? Good combination. What is the disadvantage? No? Chale. Let's see it. Has got the powerful glycemic control with empagliflozin, linagliptin. You can see that A1C reduction with the EMPA 25 and 5, 1.8% compared to the EMPA 10 and lina 5, 1.6%. Then the decrease in the weight with the EMPA lina, 3 kilograms with the 25-5, and 2.6 with the EMPA 10 and 5. Then blood pressure. Definitely these all drugs has got the good pleiotropic impact on the blood pressure, so that definitely that also decreases the blood pressure in these patients. Now, if we combine, this is just one slide of the Kremlina trial that actually shows the linagliptin on this side. It actually favors the linagliptin. Heart failure, cardiovascular death, and all-cause mortality, they are being improved by the linagliptin. Another beauty of linagliptin, that it's the only globally available DPP-4 which excreted mainly via the gut. So you don't have to be concerned about the renal EGFR and all these things, so just 5%. The other, you can see how much they are being excreted through the kidney. So that's the reason lina has got the advantage in those patients also when they have got actually the renal failure. Metformin extended release is a first-line therapy for the treatment of patients with type 2 diabetes. It's consensus from all the ADA, ESD, and ACE. But unfortunately, in this part of the world, or rather in different parts of the world, the GI side effects are 20 to 30% with the metformin. Now, that's the reason that if you look at it, the GI complications, the instant release is 26%, lekin with the extended release is 11.7%. So if you put somebody on extended release, you are actually preventing a lot of GI side effects in these patients. So the initial combination of the choice definitely then will be the metformin, extended release, the EMPA and the LENA in these patients. So in non-adherence with medication is the problem, do you think? What do you say? Yes or no? So non-adherence, as I said earlier, is a problem definitely, and this sort of combinations will improve the compliance, will improve actually the HbA1c and improve the complication in these patients. मेडिसिन एडियरेंस इन लो सोशो इकोनॉमिक कंट्रीज, बहुत से मरीज आते होंगे डेफिनेटली, मुझे पूरा यकीन है, सारे बहुत कुलीग्स सीनियर जिनकी माशाल्लाह बहुत अच्छी प्रैक्टिसेस हैं, वो बंदा कहता है कि जी डॉक्टर साहब आपने गोली लिखी है, वो तो दिन में 3 मरतबा खानी है, मैं बड़ी मुश्किल होती है, दोपहर में ऑफिस में होता हूँ, शाम को देर से आता हूँ, तो कोई गोली ऐसी लिख दें कम अज़ कम 1 मरतबा खा लूँ सुबह या रात, दैट बी वेरी कन्वीनियंट फॉर मी. सो दैट्स अ रीज़न. अगेन the non-adherence is around 29.1%. So look at it. So poor accessibility to medication, healthcare services, low level of awareness, medication side effect, complex medicine regimen, जिसकी हमने बात की, multiple doses per day and more frequent dosing of OADs. तो इन सारी चीज़ों में compliance कम हो जाती है, और जाहिर है जब compliance कम होगी तो definitely आपका A1C अच्छा नहीं रहेगा. कैसे कर सकते हैं? एक तो एजुकेशन, मरीज को समझाना होता है कि दवाई ज़रूरी है, इसके बगैर तो काम नहीं चलेगा. देन कुछ लिख के दे दें उसको. आजकल तो सारे लोगों के पास माशाल्लाह स्मार्टफोन्स हैं, रिमाइंडर लगा दे जी, भूल जाते हैं तो रिमाइंडर लगा के दवाई खा लें. Reducing the medication burden, this is something which is important. We always try to prescribe those medications which are necessary, which are mandatory for the patients. Choose medication with fewer side effects. This is something which we all do. I know that. Simplify the regimen and combination of the pills. दवाइयों को जोड़ दें, मेरा ख्याल है कि उससे बहुत फ़र्क ये होगा कि आपकी मरीज़ की कंप्लाइंस भी अच्छी होगी, उसके HbA1c रिडक्शन भी अच्छा होगा. तो this is actually, that's the reason we are here for the triple combination. क्या होगा? नंबर 1 इज द कॉम्प्लीमेंट्री मैकेनिज्म. मेटफॉर्मिन का अपना मैकेनिज्म है, लीना की हमने बात की उसका अपना मैकेनिज्म है, एम्पाक्लोफिलोजिन की बात की उसका अपना मैकेनिज्म है. तो तीनों के मैकेनिज्म को आपने कॉम्प्लीमेंट कर दिया और डोज या दवाई का बर्डन कम कर दिया. देन एडियरेंस और अच्छी हो गई कि मरीज को आसान लगेगा कि दिन में मुझे जी 1 मरतबा गोली खानी है, एंड दैट्स वेरी कन्वीनियंट फॉर हिम. इम्प्रूव सेटिस्फिकेशन, मरीज भी खुश होगा कि जी मैं बहुत सी गोलियां नहीं खाता, इट्स वेरी वेरी सेटिस्फाइंग, आई एम जस्ट टेकिंग 1 pill फॉर कंट्रोल ऑफ माई डायबिटीज. एंड द लोअर द कॉस्ट, दिस इज अगेन समथिंग फॉर आवर पार्ट ऑफ द वर्ल्ड, लो सोशो इकोनॉमिक, बहुत से लोग नहीं अफोर्ड कर सकते महंगा इलाज, महंगी चीज़ें. तो 3 गोलियों की दवाइयों से अगर हम उनको 1 गोली पे डाल दें तो आई थिंक सो दैट इम्प्रूव्स अ लॉट ऑफ थिंग्स इन दीज पेशेंट्स. So to prevent, as I said in the first slide, the goals are prevent the complications and optimize the quality of life. So this is actually nowadays actually the management strategy that we prevent the complication in these patients and the optimize the quality of life with these drugs. So combination of EMPA, LENA as a second line therapy for type 2 diabetes, which are indically controlled on metformin. So you when add these drugs, this was in a study. I don't want to go into main detail, but just give you the results. The significant reduction HbA1c with the combination of EMPA, LENA, greater proportion reduction HbA1c, compliance, reduction from the baseline in the weight, so reduction from the baseline in the systolic blood pressure. So all these combination will give you a better compliance and decrease. Okay. Hypoglycemia, which is again something which is very important in these patients. So do you think these combinations which we are talking about, they cause the hypoglycemia? Rarely. Very rarely. If they are alone, they don't do it. But if you combine them with actually the sulfonylurea, that depends on the patient, they may do, but usually these individually, they don't do it. So initial medication of the choice then definitely will be the metformin, the EMPA, and you add the LENA in these patients. So This is a fixed dose combination, which you were not saying it, but this is basically the FDA approved combination of all these three. So patients' centric glycemia, that will improve the healthy outcomes. So number one is the glucose control. Number one is the weight management, risk reduction, and actually decreases the burden of the pills or of the economy on these patients. I think so. That was the last slide. Thank you very much.
Thank you, sir, for your insights, and you made it a lot easier for all of us. So now we are going to take few pointed questions only, if there are any.
Very excellent talk. Very excellent talk regarding the type 2 diabetes mellitus guidelines and refreshing our knowledge. Just I have a few questions about the combinations. Compliance, that is a crystal ball. We all know that 3 pills combination compliance will be very much good, but I'm wondering about how is it different from taking EMPA and LENA in combination than with a metformin alone. The second important thing is the uniqueness of the combination, like the contraindications of empagliflozin in recurrent UTI, and then the contraindication of metformin, how this combination will work in that scenario. And adding on down the road, I would like to know about the personal experience. What would be your thought regarding down the road? The combination therapy would be different in terms of control from the separate. And can we add a 4th drug to this combination?
Okay. Now the first answer is that this combination therapy is not for everybody. Everybody will not be on a triple combination. This is number one. Your patient may be very well controlled on, for example, the metformin and the EMPA, which he is already taking. There is no need to escalate him. Second, someone who is already has got the GI side effects, for example, on the extended release metformin also, then definitely this is not the choice for these patients. The third, the question you raised of the infections, someone who is already has got the infection, for example, with the empagliflozin, then again definitely is not a absolute contraindication, but you give it a break, and then you can reintroduce one time to these patients. But again, to those patients who has got the repeated infections with the drug, definitely will not be the drug of choice to these patients.
Assalamu alaikum. Very excellent talk. I want to just clear, if we give metformin to a patient, maximum dose of 2 grams or 2.5 grams based upon the patient tolerability and clinician choice. In this combination, how can we give a patient 2 gram maximum dose of metformin?
I think so. I said earlier that this is something which is not being given to everybody. For example, some of your patients who are, for example, on a metformin of, for example, 500 milligram BID with another drug, and you think that a combination will prevent the, for example, the A1C reduction. On 2 drugs, for example, one of your patient who is on a metformin and the empagliflozin has got the HbA1c of about 8%, that you have got the choice. Either you escalate, split the drug, escalate actually the metformin, or you escalate with the combination which is available, for example 12.5 and 1000 of the metformin with the empagliflozin. Or the third choice is with you, is that you just reduce the pill burden and you add the third compound, which is the linagliptin, and try to control the patient. This is always your choice. This is not mandatory that we use this drug, but this is always your choice with the patient.
We're very short of time.
Very quick. A patient is not controlled with a triple combination. Would you like to add a 4th drug, or would you like to add a basal insulin? What will be your thought? And
Yes.
Again, that depends on the patient, what sort of patient I'm seeing. For example, somebody who is not controlled on this triple combination, is still the HbA1c, just giving you an example. If the HbA1c is again 9%, his fasting blood glucose levels or again 170, 180, the basal insulin is the answer. But someone who has got, for example, very obese patient, then I may switch or change the combination therapy in a way that I take out the DPP4 and put him on a, for example, the GLP-1 injectable once a week. That again depend on you, how you treat your patient.
Thank you, sir. Now, very quickly, some comments from the panelists, please.
Is it on now?
Yeah.
Yeah, thank you. Dr. Saeed had an excellent, very engaging talk. And although these are concepts which have been, we've been familiar for so long, but his method of delivery, his interaction was, I think, very, very impressive. I think he deserves a hand of clap for that. So as Dr. Saeed summarized, I think he covered virtually everything. So here you have drugs with complementary mechanism of action. So therefore, on one hand, you're causing negative energy balance and the cardiovascular benefits to the SGLT2, and you are getting a mechanism of action through the kidneys. On the other hand, you have a mechanism of action through an incretin effect through the linagliptin with a safety, no additional risk. And then metformin is addressing the third area of insulin resistance. So complementarity is such a beauty, and all in one pill. So yes, I am a big fan of the combination. There are challenges with finding the exact combination which you need for your particular drug specific, but then there are so many combinations on the market, so many different formulations. So we can always come up with an exact requirement. That's the answer to that question from Maitri.
I would like to first of all congratulate Saeed for presenting the topic very comprehensively. Obviously, as Dr. Khadija has pointed out, complementary mode of action, combined tablets, convenience for the patient, and improves the adherence. So improving the adherence improves the control of diabetes. My question to Saeed, maybe the company can respond to it, the technology that is used to manufacture these extended release tablet, how good the technology is in Pakistan, is it comparable to the Western world technology? Is it the same technology by different companies out there? This technology is different, so maybe Saeed can answer or somebody from the company can answer this. So my concern is about the technology. I know the combination is a good combination, but obviously it has to be individualized, and the dose has to be individualized as well. But I think the technology, and the good thing about this combination is that as a result of this competition between the pharmaceuticals, they have dropped the price, which is good for the patient. Now the range is between 14 to 20 rupees. I think, I hope they don't increase the price 6 months down the line.
Let's hope so. Thank you, sir. So now we have got some shields to be quickly distributed among the panelists and speakers. I will request Dr. Saeed Mahar to come, please. Sir, please come on stage. Dr. Saeed Mahar. Okay, so Professor Dr. Najmul Islam Sahab is going to present the shield to Dr. Saeed Mahar Sahab. Now, Professor Najm Sahab to present the shield to Madam Khadija. Now, a shield is to be, okay. Now, Professor Saeed is going to present to Dr. Najmul Islam Sahab. Thank you very much. So with this, we conclude. We are going, this is a small announcement. We are going for a very short tea break, for just around about 10 minutes, and you're requested to please join us back for the next consecutive session. Thank you.